You can see here that the cost is very, very significant for any skeletal-related event all the way across the spectrum to spinal cord compression and needing emergent surgery. So what I want to do is I want to break the talk sort of into two halves. The first half is the much more common problem that we face, and that's the use of ADT and osteoporosis. And then the second part of the talk, we're going to specifically talk about morbidity and mortality of bone metastasis in prostate cancer and exactly what we can do to help our patients in 2017. So here's the number of patients with fractures 1 to 5 years after the diagnosis of prostate cancer. This is all comers, and it is broken down by patients who are on ADT or patients who did not receive ADT. And again, you can see that the ADT very significantly increases the risk of a fracture after the diagnosis of prostate cancer, regardless of the stage of the disease. And again, survival after hip fracture is much worse for men than it is for women. So osteoporosis does increase with ADT duration, although you can have an initial hit on androgen deprivation and the impact on osteoporosis the first 2 years. The longer you're on ADT, it continues to increase, and at 10 years, almost 80% of men have some form of osteoporosis due to the androgen deprivation therapy. So how do we diagnose osteoporosis? Well, clinically, bone marrow density, we all know, remains the gold standard. And bone mineral density, whether it's in men, women, children with corticosteroid-related disease or whatever, remains the best determinant of our bone strength. And it highly correlates with the fracture risk. And it is as reliable as blood pressure is in predicting a stroke. So this is the WHO criteria for osteoporosis by DEXA scanning. This is all age-corrected and age-adjusted, so when you get a report back on the DEXA, it should be for an age-corrected individual. So a normal is a -1 and above. Osteoporosis is diagnosed with a T-score of less than -2.5. Osteopenia is low bone mass. It's basically between -1 and -2.5. So this is a very useful tool if you want to get very serious about managing patients in your practice, whether it's a men's health clinic or relating to androgen deprivation therapy. You can go to the WHO FRAX risk assessment, and you look at a variety of issues, whether someone's had a fracture, what their weight, what their height, what their age is, whether or not they've been treated with androgen deprivation therapy, and it gives you a very reliable risk score for the patient's chance of having a fracture in the next 10 years. Now, if you have osteoporosis, and we'll talk about bone metastasis a little bit later, but these are sort of kissing cousins in respect, because almost always patients who have osteoporosis and then develop bone metastasis are managed in a similar fashion. So our mainstay for the management of osteoporosis is vitamin D supplementation. If you have vitamin D levels, if you're really serious about this, checking vitamin D levels on patients is the best way to accurately assess, do they need vitamin D supplementation at all? Are they getting enough in their diet? Or does an endocrinologist really need to give them supplementation for whatever metabolic reason that they're not generating enough metabolically active 25-hydroxy-D, which is the only accurate way to really determine a patient's true vitamin D level. So if you look at calcium supplementation, it's a little bit crazy. If you look in the literature, what's out there, there's some very recent data that came out about 2 or 3 years ago. As always happens, some papers have suggested that men who get too much calcium actually increase their cardiovascular mortality by greater than 20%. A lot of groups now recommend just getting most of your calcium through diet and supplement, if needed, with only 600 milligrams of calcium a day. What I tell all my patients who are on androgen deprivation therapy or anybody who's on steroids or any kind of risk of of osteoporosis. I think the best thing to do is just send them to get Caltrate 600 plus D3. It's relatively inexpensive. You don't need a prescription for it. It's over the counter, and that has 800 international units of cholecalciferol. So I think that to me is the easiest way, and that abrogates most of the issues. And again, if you're real serious about it, you can send them off for a vitamin D level, but I think in most patients it's probably necessary. That falls more into the area of endocrinologists. Bisphosphonates have been with us for several years now, very popular in women, not so popular in men, but starting to get more and more traction in that area. Bisphosphonates inhibit osteoclast activity and reduce bone resorption, and they can increase bone mineral density in the hip by up to 6%, but it takes a few years for that to happen. They can reduce the incidence of vertebral fractures by up to 70%. But remember, one of the things, and those of you that really want to do a deep dive into the area of osteopenia and osteoporosis, is the concept of morphometric fractures. They're not clinically apparent fractures, but if you do detailed spine films, you can pick up these small linear fractures. They may not cause a change in the vertebral body, but these are counted by some papers as a skeletal-related event. We'll talk about skeletal-related events a little bit later. Important thing is they have a low GFR. Bisphosphonates are contraindicated. And again, of course, anybody that you're putting on a bisphosphonate, you should seriously consider a dental exam before you actually start it because of ONJ risk and every 6 months during it. The main side effect of bisphosphonates, I think everybody's aware of, that we worry about, is certainly the osteonecrosis of the jaw. But a new thing is coming out in the literature that's been added to the label, and that's atypical fractures of the femoral shaft, which is sort of illogical. You'd think you're strengthening the bones, but it has now been added to all the package inserts of the bisphosphonates that you may increase the risk of a femoral shaft fracture. The other drug that's out there, if you want to get really serious about treating osteoporosis, is denosumab, which is a rank ligand inhibitor and reduces bone resorption as well through a different mechanism. It increases bone density probably a little bit more than the bisphosphonates do, and it decreases the incidence of true vertebral fractures of 68%, but much more than the bisphosphonates, it actually decreases hip fractures by up to 40%. These are the common osteoporosis agents that are approved in men. The oral bisphosphonates, there's parenteral bisphosphonates. We tend not to use too much in urology, but there are some practices that do intravenous administration of zoledronic acid. Prolia and denosumab are probably and Exgeva are probably the more common agents that a lot of urologists use. Everyone knows there's two forms of denosumab. There's the Prolia, which is basically meant for men with androgen deprivation therapy, induced osteoporosis, or just out-of-the-gate osteoporosis through smoking or chronic steroid use or something else, and very different dosing. The Exgeva is the form of denosumab, which is, of course, used much more aggressively. It's not really meant for men with osteoporosis, or a lot of men who do have bone metastasis have long-term osteoporosis from their androgen deprivation therapy, and that's a much more aggressive regimen of 120 milligrams sub-Q on a monthly basis. At the present time, the National Osteoporosis Foundation has guidelines for fracture prevention in men. They don't necessarily say you have to use FDA-approved agents. Everyone is completely in favor of vitamin D and calcium supplementation. But the National Osteoporosis Foundation suggests that if men have a history of a vertebral fracture or hip fracture, if they have a bad T-score, putting them in the osteoporosis category of a T-score of less than minus 2.5, or you do a FRAX score on them and you consider all the other factors that the FRAX score look at. If they have a greater than 3% risk of having a hip fracture at 10 years or a 10-year probability of any other fracture greater than 20%, you probably should go ahead and treat them with an FDA-approved agent, a bisphosphonate or denosumab or something like that. Interesting program down at Duke that they developed called a Healthy Bone Program. And what this group down there was able to show that using their regimen which goes as follows. They get a DEXA scan. This is for every man, not just patients with prostate cancer or ADT osteoporosis. Every man gets a DEXA scan in this practice world. Men age 50 undergo screening if they have additional risk factors, and in our world, that's androgen deprivation therapy. Basically, they have a program that focuses on clear smoking cessation, regular exercise, calcium, and vitamin D intake. And if you have a really severe T-score of less than minus 2.5, they recommend pharmacologic intervention. And in this men's health primary care practice setting, the patients are referred to an endocrinologist for more aggressive management. Next, I just want to move to the other area which creates a lot of problems for us in the field, and that's bone health in patients with metastatic prostate cancer. We're going to talk about these four major areas and talk about can we really be doing more to help patients in 2017. Skeletal-related events, depending on which paper you read, people will pull out different skeletal-related events. The ones that are most commonly agreed to in most papers are a pathologic fracture, spinal cord compression, the need for radiation therapy to the bone, any type of surgery needed to stabilize a bone fracture are accepted as skeletal-related events in men with bone metastatic disease. So the impact on bone metastasis on survival is very significant. And again, if you look at the patients, the time after initial prostate cancer diagnosis in years, little more than 50% are alive at 5 years without bone metastasis, but those with bone metastasis, according to this 2010 paper in the Journal of Urology, very few are alive after 5 years. The site of prostate cancer metastasis on survival, if you look at the curves here, you'll see that the lymph nodes only disease tend to do the best, and as you get bone lesions, your survival goes down. And once you begin having both bone and visceral metastasis, those patients have the worst prognosis and the lowest survival. So the site of metastasis can have an impact on survival, and certainly in this category, disease to the bone gives you the biggest hit on your chance for survival. So over 90% of patients with metastatic castrate-resistant prostate cancer ultimately will experience a skeletal-related event. And again, as we mentioned, the skeletal-related events are not good. They include spinal cord compression, fractures, need for surgery or radiation therapy, and they are really the major cause of death and disability and, of course, quality of life of a lot of our patients. The anti-resorptive bone-targeted therapies are top line here. We're not talking about using the standard oral bisphosphonates in this setting. If you want to be serious about helping stabilize men's bones with metastatic prostate cancer, you've got to get into the systemic administration, either the zoledronic acid or denosumab. Now, the good news, bad news is that really these agents do not necessarily extend survival if you're using them for specifically skeletal-related events. They do, the denosumab has been shown better to extend survival. I'll show you the data in a minute. They don't delay metastasis, and in sub-studies they delay or prevent skeletal-related events. But again, the papers are all over the place. About 50% of men with castrate-resistant prostate cancer will develop metastasis within 2 years of the CRPC diagnosis. And again, the literature is really very evolutionary at this point. Traditionally, the median survival of men with metastatic castrate-resistant prostate cancer is reported to be less than 30 months, but we know with advantages in our various treatments that is extending. More than 30% of men with simply a rising PSA and no evidence of obvious metastatic disease actually harbor METs based on how aggressively you image these patients. And Dave has alluded to this several times, the famous RADAR study. The goal, if you have patients who are M0 and you want to offer them advanced castrate-resistant, metastatic castrate-resistant prostate cancer therapy. They're only approved in the setting of radiographic metastasis. So these men probably need to be imaged a little bit more than we are currently doing it. And in particular, that panel on the right, the first scan with the PSA level is greater than 2 nanograms per mil. For the M0 CRPC patient, the more you look for it, the more you're going to find it in the appropriate patient. And again, I think this paper is getting a lot of traction, and a lot of people are recognizing that patients need to be imaged a little bit sooner to look for the metastatic bone disease. Alkaline phosphatase is, we'll talk about some of the latest data out there with radium-223, but ALK-Phos, an oldie but goodie, actually predicts the risk of bone metastasis in asymptomatic patients who are treatment naive. And the data here is even getting more pronounced with radium-223 that we'll talk about in a couple of minutes. So NCCN guidelines do talk about patients with M1 disease, frank metastatic disease, and they talk about bone resorptive therapy with either denosumab or zoledronic acid, and they both consider these to be category 1 if bone metastases are present. So that gets a pretty high level of endorsement from the NCCN. A phase 3 study of zoledronic acid versus denosumab in identifying the time of the first skeletal-related event suggests that there was a slight advantage to the use of denosumab in patients in delaying the first skeletal-related event. So if you look at the adverse events, if you're going to choose to use zoledronic acid or denosumab, they have a lot of common side effects. One of the very interesting things is that you have to be aware of, number one, if you use these agents, you must absolutely positively make sure patients have adequate calcium and vitamin D supplementation. One of the side effects of both of these anti-resorptive agents can be hypocalcemia from inadequate intake of calcium. So these patients really need to be monitored very closely for their calcium and vitamin D intake. And I know early on, ONJ of the jaw was thought to be isolated to the bisphosphonates, but the more and more that denosumab, the rank ligand inhibitor, was used, we also now see an increased incidence of osteonecrosis of the jaw. Acute phase reactions, again, tend to be a little bit more acute infusion. I have a very first time I ever used, the first time I gave an IV denosumab was the last time I gave it because the patient ended up in renal failure, so I now let the medical oncologist give the systemic therapy. But did I say that? I meant zoledronic acid, Zometa. IV zoledronic acid. The man ended up in the acute renal failure in the hospital for 2 or 3 weeks. So I now let the medical oncologist, like Dr. Petrolak and everything, manage that. But again, remember, ONJ can be seen with both denosumab and zoledronic acid. So there was a consensus panel known as the St. Gallen consensus that happens in Europe every couple of years. And this is basically a group of medical oncologists, urologists, radiation oncologists, and others that address a series of issues. And they get together and they work their way down to recommendations on how patients should be treated. And basically, if you look at vitamin D and calcium supplementation as a baseline for patients with newly diagnosed castration-naive prostate cancer, they agree with vitamin D and calcium supplementation, but they don't necessarily recommend zoledronic acid or denosumab. For M0 CRPC, this consensus group actually did not recommend the use of osteoclast-targeted therapies in the M0 setting. However, once you got to frank bone metastasis, everybody was basically on board with the use of either denosumab or zoledronic acid. They did not really come up with a strong recommendation of one over the other. But in the setting, again, to remind everybody, once you have documented M1 CRPC, that the standard of care should be some type of anti-resorptive therapy, either denosumab or zoledronic acid. But what's new in the area? Everything which is old is new again. And, of course, the Curies discovered something known as radium in 2 centuries ago now. It's hard to believe. They got the Nobel Prize with Henry Becquerel for this discovery. They noted basically around 1900 that radium could be a cure for cancer. And a lot of work was done with radium. Unfortunately, in the early part of the 20th century, it probably caused more cancers than it cured because people didn't exactly know what they were doing or had no understanding about how radium actually worked. I always like this because it reminds me why we study chemistry in high school and in college, because the periodic table comes back to haunt us here. And if you look at the reason that radium is used to treat advanced prostate cancer now, that it targets osteoblastic bone metastasis by acting as a calcium mimetic. And if you look at strontium, which we'll talk just briefly about, all of these are calcium mimetics and are very useful in the treatment of advanced prostate cancer. So as a calcium mimetic, it is bone-seeking and it binds to hydroxyapatite. And again, the problem with prostate cancer, as you know, there is both bone creation and bone resorption. The problem is the bone that gets created is bad bone. It's not necessarily very stable bone. So although you have an osteoblastic metastasis, it is not a stable growth of new bone. It's actually very bad bone. So we're all familiar historically with strontium and samarium. They were kind of the go-to radiopharmaceuticals in the 80s and in the 90s, and they're actually still around, but really not used that much. They're primarily beta emitters that were used for palliation. The new kid on the block over the last 10 years has been radium, rediscovered over 100 years after its initial discovery as an alpha emitter. And the clinical benefit of it has been shown in clinical trials to reduce skeletal-related events and to improve survival. Remember, strontium and samarium was strictly for palliation, but did a big number on the bone marrow for reasons that we'll talk about. Very critical to understand the difference between alpha and beta emitters. Alpha particles are very large and don't travel very far, and you can basically stop them with a piece of paper. Whereas beta emitters, very small and have a very long distance of travel because they don't get stopped very easily. But if you look at the bottom, the DNA hits to kill cells. Alpha is very big and very deadly. It takes very few relative hits of the DNA to kill a cell, whereas beta, you need to keep hitting the cells for reasons that we'll talk about. The reasons are that if you have beta and gamma radiation, they tend to only induce single-strand breaks in the DNA, which the body can repair more easily. Once you get double-stranded breaks in the DNA, and that's where the alpha radiation really shines, much more lethal to the cancer cell and much more difficult to repair. So the bottom line is that our new compound that we have, the radium-223, alpha-radon, is very, very short range, but has a very deadly kill. And the benefit that we have here, if you look at it, is that it minimizes the damage to the bone marrow. Strontium and samarium were notorious at knocking out the bone marrow. They gave patients some palliation, but usually you can only give the medication once and sometimes twice before you really wiped out the bone marrow. Particularly the platelets were very sensitive to the beta emitters, whereas the radium-223, you could see here, is pretty kind to the bone marrow. Here's an example of a choline PET scan showing a very pronounced response to radium-223 in a patient with metastatic prostate cancer. An interesting little aside is the fact that initially radium-223 was developed as a palliative drug. And the development shifted quite dramatically because although it can palliate patients, they suddenly recognized patients were living longer who were getting radium-223. So the whole work shifted towards now using it as a therapeutic agent, and that's where the work started to change over 6 or 7 years ago. So the famous article that came out was the alpha-radon study with Chris Parker as the first author now almost 4 years ago, showing that radium-223 in the Alsimca trial could extend survival. And basically these were patients with castrate-resistant prostate cancer who either had docetaxel or were unfit for docetaxel, and they were randomized 2-to-1 to either get a placebo or get 6 monthly doses of radium-223. And the bottom line is that the radium-223 increased the overall survival by a little more than 3 months. And again, our MCRPC drugs, as you all know, we're kind of locked in this 3 to 5 month survival advantage, but hopefully by layering these different drugs on top of each other in the coming years, we're going to be able to expand the survival. Very pronounced improvement in time to first skeletal-related events in patients who got the placebo versus the radium-223, about a 6-month improvement. And the main things, again, you need to still worry about, although the drug is friendly to the bone marrow, you can still see problems with anemia and thrombocytopenia, so you need to check cell counts before you start the patient and before each subsequent administration. The other thing, since this drug is secreted through the GI tract, some patients actually can have some nausea associated with it. So basically, radium-223 can prolong overall survival, and it also prolongs time to first skeletal-related event. And overall, compared to other agents in this space, it is well tolerated. So an interesting paper was produced about a year and a half ago by Oliver Sartor, where, remember, it's given monthly for up to 6 months, and Oliver was able to show from an early access program that if patients got less than 4 injections, they did not do as well, that patients were able to complete the entire cycle of 6 monthly injections. Papers have looked at combining radium with bisphosphonates, and basically no extent in survival, but it did have a positive impact on symptomatic SREs. So again, since most of these patients are on some sort of anti-resorptive therapy, they get continued. Our friend alkaline phosphatase in a phase 3b study was really shown to be a very powerful marker, and in fact more reliable marker than PSA. And again, we have the problem with the PSA not necessarily responding that vigorously with the radium-223, but ALK-Phos has proven to be a reliable marker. Radium-223 is only to be used without visceral disease, only in patients who have bone-only disease. That's the current label. If you look at it, it's known as Xofigo from a proprietary standpoint for the treatment of patients with CRPC, symptomatic bone metastasis, and no known visceral disease. The little thing, those of you that follow this, there was a slight change in the label. The National Institute of Standard and Technology changed how they measure radium-223. From a practical standpoint, there's no difference in how the drug is administered, but if you look at the package label, it changed from the original approval to the actual total dose of radiation that the patients were getting. Our team at Jefferson, the Kimmel Cancer Center, uses a lot of radium-223, and we wrote this practical paper on how do you administer radium-223, because it's not simple. You've got to do a lot of advanced planning. At our shop, it's given by the radiation oncologists, and other shops, it's given by the nuclear medicine folks. But you got to make sure that you have proper setups in Canada and the United States. I know we have some Canadian colleagues here. They are slightly different in the label, and the paper goes over those differences. But the important thing is always check the laboratory parameters at the start of therapy and during therapy. And if you don't get a recovery of a very low lab test within 4 to 6 weeks, you have to go ahead and discontinue the use of the drug. So the bottom line of bone health is patients on ADT, you should consider DEXA scanning and use basic management strategies before you get into drug therapy. Strongly consider anti-resorptive therapy with M1 disease, and I think it's generally considered standard of care to use denosumab or zoledronic acid for those patients. Radium-223 can help with symptoms and bone metastasis, but also can extend survival. And you really have to have a good institutional program or support to use radium-223 in your clinic. You need a lot of coordination of the care.